Melatonin. What is it good for? Well, maybe some things. In my most recent video, I shared my general skepticism regarding the use of melatonin for people with chronic insomnia based on our most current data. Many of the comments I received inspired me to take an even deeper dive into melatonin to explore all of its other uses, and let me tell you, it's quite the rabbit hole. For this video, I'm going to focus specifically on its use for regulating sleep in neurodivergent individuals and in perimenopause, as well as treating disorders including dysautonomia, migraines, and other headache disorders. Overall, my search revealed a plethora of studies regarding melatonin's natural physiologic roles within the body, but clinical studies for the use of supplemental melatonin remain pretty limited across the board. But we do have ample evidence showing us that melatonin dysregulation is clearly very common in the populations and disorders I listed previously. This dysregulation is then linked to disruption of the usual circadian rhythm among other bodily processes, which makes supplemental melatonin quite the attractive potential treatment. In terms of treating sleep disturbances, specifically in ADHD and ASD, I was only able to find quality studies performed in small pediatric populations. Despite the limitations of these studies, there was a significant positive response to supplemental melatonin in improving both the sleep latency and sleep duration in children with ADHD and/or ASD. Given that side effects were overall minimal and the data that we do have appears promising, I would love to see larger studies performed in both children and adults, especially since this treatment really makes sense on a physiologic basis. So what about melatonin for sleep in perimenopause? In the small studies we have available, supplemental melatonin did not improve sleep quality in women going through perimenopause, but it actually improved the physical symptoms of perimenopause. So if melatonin appears to improve physical symptoms in menopause, can it also improve other non-sleep related symptoms in other disorders? In MS and POTS, the few clinical trials we have available show improvement in certain parameters with the use of supplemental melatonin, such as heart rate variability and inappropriate tachycardia. However, these effects did not actually lead to a clear improvement in the symptoms of dysautonomia. Melatonin has been proven to decrease the sympathetic nerve response through its action on GABA receptors, so this treatment does make sense on a physiologic basis. However, further research is needed to determine its true clinical efficacy, as well as establish dosing and clinical protocols for various types of dysautonomia. In terms of treating migraines and other headache syndromes, early clinical trials appear really promising. In one of the trials, melatonin was actually just as efficacious when compared to amitriptyline and propranolol in terms of preventing migraines, and with fewer side effects. Again, larger trials are needed to further validate this data and establish clinical protocols. But what we have so far seems really promising. If you enjoyed this video, please consider checking out the associated article on my Substack where I go into an even deeper dive, including melatonin's potential effects on bone health and osteoporosis.